Moving on to the next session, bronchial asthma and acute respiratory infection in pregnancy. To chair the session, I call upon Dr. Praveena Elizabeth, Dr. Reggie Jose, Dr. Shyamala Menon, and Dr. Asha Rajan. Over to the chairs.
Hello. Good afternoon. At the outset, let me thank on behalf of my co-chairpersons and myself for giving us this proud privilege to chair the session. Today the topic is a very common topic, bronchial asthma and respiratory infection. So what are the drugs to be used and not to be used? What are the red flag signs? What are the indications of inhalers, oral inhalers, steroids, all these things? I think we have got an excellent speaker, Dr. Rajesh. He's the HOD of the Pulmonology Department of Rajagiri Hospital. And over to you, sir.
Thank you, sir, for those kind words. And I would say very good afternoon to the esteemed faculty, delegates, and organizers. And I would like to place upon record my sincere gratitude for allowing me to be a part of this to the organizers, especially Sunny sir, our medical superintendent at Rajagiri Hospital. So all of us do acknowledge that asthma is one of the commonest medical disorders that we encounter in our pregnancy. A substantial chunk of asthmatics can be managed just like a non-pregnant lady. There are no complications there, but a small subset actually present with challenges, and this is what we are trying to look at in today's talk. So the next 20 minutes or so, I will try to share with you the prevalence of asthma in pregnancy as a disease state, the general respiratory physiology in pregnancy, as well as the pathophysiology of asthma in pregnancy. A few words about the mutual impact, that what asthma can do to the pregnancy and pregnancy outcomes, and what pregnancy can do to the natural history of asthma. Then most importantly, the management of asthma in pregnancy, which especially emphasizes on the drugs and their safety, and a very few statements on respiratory infections. Then I start off with a disclaimer that I am sharing a few real-life cases, and I am focusing on asthma predominantly with a very sneak peek into the respiratory infections only. So if you look at asthma and pregnancy, as I said previously, it is one of the commonest chronic pulmonary diseases encountered during pregnancy. Depending upon the scenario that we practice, up to 3 to 8% of pregnant women might have an asthma history, can be even up to 10 to 12% in very specialized obstetric settings or very specialized pulmonary settings. And as I said previously, there is a very complex interplay between asthma and pregnancy. Pregnancy can affect the natural course of asthma, how asthma behaves. And asthma as well as its treatment can affect the outcomes of pregnancy, both maternal as well as fetal. This is a simple representation of the physiology of lung volume during pregnancy. This is not an asthmatic lady, but a usual, otherwise a non-asthmatic lady, what happens is, as the pregnancy duration of gestation progressively increases due to the enlarging uterus, the diaphragm tends to elevate. The functional residual capacity tends to decrease in the second and third trimesters, depending upon the size of uterus. Around 20% decrease in FRC occurs by the third trimester. Whereas the total lung capacity and vital capacity are usually well preserved till the third trimester. In general, the bronchial hyperresponsiveness, if we see in a non-asthmatic lady, the bronchial tone is actually better. So the patient tends to be less prone for bronchial hyperstimulation in pregnancy, but that is a non-asthmatic lady. If we look at asthma, I will just share a real-life case. This is a 27-year-old primary gravida. She presented to us at 8 weeks of pregnancy. She is allergic from late childhood, predominantly nasal symptoms like sneezing and watering of the nose, wheezing only during respiratory infections, on as and when required salbutamol inhaler, no recent spirometry, and she is desirous of knowing how her disease will be causing during pregnancy and the outcomes of pregnancy. So this is one of those landmark papers which looked at the fate of asthma during pregnancy, and it actually concluded that around 1/3 of asthmatics actually get better with pregnancy, 1/3 have a static course, and 1/3 are actually worse. In 1/3 pregnant ladies, their asthmatic symptoms tend to get worse. There are other papers which say that up to 60% of patients become static or stable and 40% worsen, but this is one of those landmark papers that is often quoted in literature. And in general, asthma severity prior to pregnancy is a very strong predictor of asthma severity during pregnancy. Someone who was very well controlled prior to pregnancy tends to retain that control during pregnancy also. Someone who has had frequent exacerbations tend to exacerbate during pregnancy also. And in those women where asthma worsened, the increase in symptoms was seen in the second and third trimester. And in general, asthma is less severe during the last 4 weeks of gestation and during labor and delivery. If you look at asthma exacerbations, exacerbations are very common during the mid-trimester. And that if you look at the asthma, how does it affect the outcomes of pregnancy? Again, one of those very huge papers of around 2.8 lakhs of retrospective data, 2.8 lakhs of pregnancies with around 38,000 asthmatics. What it said was there is a very, very mild increase in the miscarriage rate, but in general, the fetal outcomes are pretty good in an asthmatic pregnant lady. Similarly, the complications of pregnancy with asthma, if you look at, there is a mild increase in the antepartum hemorrhage rate, a mild increase in the rate of thyroid disorders and depression, and maybe slight increase in the incidence of preeclampsia. But what is crucial is that these adverse outcomes are much more common if the asthma is severe or uncontrolled, which again means that exacerbations and severe asthma symptoms is the one we should really target. So why worse outcomes? As I said previously, hypoxia and other direct consequences of poorly controlled asthma like hypocapnia, alkalosis, all those things can affect the uterine circulation. And complications of asthma medicines by and large is pretty less because we have very safe medicines now. The most important thing will be poor adherence to asthma treatment during pregnancies because of concerns of adverse drug events. So many of those pregnant ladies tend to de-escalate or stop medications, and that actually translates to the worse outcomes during pregnancy. If you look at asthma diagnosis, usually it's a straightforward diagnosis because a lady who is otherwise a non-asthmatic becomes pregnant and has consistent symptoms. So that is pretty straightforward. But sometimes we can have de novo asthma symptoms during pregnancy, which probably is due to unappreciated mild pre-existing asthma. That is the most common scenario. Sometimes viral infections like respiratory syncytial virus and influenza can trigger cough and wheeze, which can give rise to transient asthma-like symptoms during pregnancy. Here I will come to another case of around a 28-year-old lady, priming gravid at 11 weeks with left-sided chest pain and breathlessness for 3 days. Now, she had a very shallow breathing, so physical signs were very difficult to elicit. She was advised to chest X-ray, but she was concerned, so avoided, sent home on inhalers empirically. Within 48 hours, she presented with worsening symptoms. So this time we convinced her to take an X-ray. And this X-ray, I don't know whether it projects nicely, but there is a small left-sided pneumothorax, which was managed appropriately with resolution of symptoms. Again, a 29-year-old lady, priming gravid at 23 weeks with new onset wheeze, right-sided pleuritic chest pain and central chest tightness for 3 weeks. Her examination findings were suggestive of a right-sided pleural effusion, confirmed on a USG thorax, aspirated. We had an exudative lymphocytic fluid with an ADA of 38. People felt that we might even go ahead with an empirical ATT, but we still had some persisting physical findings. So again, we wanted to go ahead with some radiological investigations. So this was the chest X-ray which made us think that there was significant mediastinal widening. So we again made her convinced and go ahead with the CT of the thorax, which actually showed a huge conglomerate lymph nodal mediastinal mass. We did a biopsy and it was a primary mediastinal large B-cell lymphoma, which we managed both with good pregnancy as well as fetal outcomes. I think Pailisa knows this case. He was part of the management team. And so what I try to tell with these two cases is that even in the period of organogenesis, if you look at the threshold radiation dose for teratogenesis, it is much higher than what we deliver with our usual X-rays. Even 1,000 X-rays and even 10 to 100 CTs may not deliver a very high teratogenic dose. So I'm not saying that we should unnecessarily utilize this test, but if there is a clinical need, we should not be hesitant to go ahead with these radiological investigations just because the patient is pregnant. Spirometry, in general, studies say that it is safe, but on a personal note, I will probably avoid, especially if the patient has a threatened abortion, incompetent dose, antepartum hemorrhage, etc., etc. And asthma is a clinical diagnosis. We don't mandatorily require a spirometry, and treatment modalities are reasonably safe. So, if the clinical features are consistent, I won't go ahead with the spirometry during pregnancy. I will rather treat the asthma with appropriate inhalers and such stuff. Now, coming to the most important part, that is the asthma medications and the safety of drugs. Here we have a 31-year-old lady, her second pregnancy, 6 weeks now. She's a doctor, asthmatic on salmeterol fluticasone inhaler. She is reasonably controlled, but she has previous documented exacerbations when she tries to discontinue her inhalers. So she is apprehensive to use inhalers during this pregnancy and she has come to us. So the general rules of treatment in asthma is that the pharmacotherapy principles are similar as in a non-pregnant lady. And more importantly, concerns about the potential risks of asthma medication are much outweighed by the potential adverse events of untreated asthma. So go ahead and treat because untreated asthma is much more complicated and problematic than concerns about the potential adverse effect of treatment. This was one of those landmark papers which looked at patients with persistent asthma, mild SOS asthma they were excluded, but persistent asthma, they grouped into two ICS, inhaled steroids versus no inhaled steroids, and exacerbations were 4% in those who used inhaled steroids versus 18% in those who did not use inhaled steroids. So definitely inhaled steroids in persistent asthma in pregnant ladies prevent acute exacerbations. Very, very important because acute exacerbations are the ones that have the maximum consequences on maternal as well as fetal outcome. The safety, in general, topical or inhaled medications are preferable to a systemic one, that is very clear. And then older or a more experienced medication with a proved safety track record is preferable to a new agent. So which inhaled steroids to prefer? In general, budesonide is the preferred inhaled corticosteroid in asthma because more published gestational human data are available. As Neeraj said in the previous talk, we may not have randomized controlled trials in pregnancy, but we have reasonably safe human data, retrospective human data of budesonide. And last couple of decades, we have promising safety data for fluticasone also. So the preferred would be budesonide and fluticasone. But if the patient is on something else like a mometasone or a cyclisonide and she is very well continued with that, you can continue because there are no proven teratogenicity in human studies, and if there are concerns that changing the inhaled steroid might worsen the control, that may be given due importance. So this is one of those retrospective studies of around 2,700 pregnant ladies who used inhaled steroids. Their pregnancy outcomes were pretty good. And again, around 5,000 mothers were exposed to fluticasone in the first trimester. Again, the concerns are not that much at all. That much about inhaled steroids, but usually in asthma we combine an inhaled steroid with an inhaled beta-2, long-acting beta-2 agonist. So here there are two agents that are preferred, salmeterol and formoterol. Salmeterol is the agent of choice because of the long clinical experience and safety profile. But of late there are reassuring data for formoterol also. Continuation of a long-acting beta-2 agonist in persistent asthma during pregnancy is advocated, but it should be combined with an inhaled corticosteroid. So again, data on almost 7,300 pregnancies with around 70% of them use salmeterol and 30% use formoterol, and hardly any concern for increased adverse events. So summarizing long-acting beta-2 agonists, salmeterol and fluticasone have limited. They say limited because there are not randomized controlled trials, but they suggest safety. Animal toxicity is observed in a very few number of studies, but most of those animal studies are reassuring. Other newer ones like indacaterol, bilanterol, etc. don't have human data. Leukotriene receptor antagonist like montelukast is also having a good safety profile during pregnancy. Antihistamines, again, the first generation antihistamines like hydroxyzine, promethazine, etc. are category C. Chlorpheniramine, diphenhydramine are reasonably safe. The second generation, cetirizine, levocetirizine, loratadine are reasonably safe. Fexofenadine is category C, but there are emerging data with comparing fexofenadine with cetirizine also which says that both are almost equally safe. But again, the problems with uncontrolled asthma and rhinitis are much more higher than concern with the drug effects. Immunotherapy, by and large, don't initiate in pregnancy because if there is a systemic reaction occurs, that is detrimental. But someone who is continuing on immunotherapy prior with no documented reaction, then please go ahead and continue. This one probably there are no much data, that is monoclonal antibodies in pregnancy. Omalizumab is the only drug with some human data in pregnancy, which says that it is reassuring. But again, I take this data as a very important thing because these monoclonal antibodies are tried only in the severe asthmatics who actually require frequent bursts of oral steroids or maintenance systemic steroids. So, if they can be proved to be beneficial with asthma control, then definitely I think we should be using them even with whatever little literature that is available. This particular data on omalizumab looked at 250 pregnant ladies with severe asthma requiring systemic corticosteroids, and they said that the congenital anomaly rate and all those things were not different, and the occurrence of bad fetal outcomes were also pretty bad, pretty good. So that takes us to the red flag signs of asthma in pregnancy. So symptoms like worsening of shortness of breath and wheezing, especially if magnitude of change from the baseline is high, then these are red flag signs. Persistent troublesome cough can have impact on abdominal pressure. Cough with purulent expectoration, there may be bacterial upper or lower respiratory infections. Fever with respiratory symptoms, there may be bacterial or viral infections should be taken seriously. Inability to lie flat may signify severe bronchospasm or LVF, so very important. Unilateral persistent chest pain is very important because there may be effusion, pneumothorax, pneumonia, even embolism. Persistent wheeze for many days, so there may be a differential of stridor that I showed in my previous one of those cases. So these are all red flag symptoms in pregnancy. And red flag signs, tachypnea is important, significant work of breathing, respiratory distress is very ominous, extensive persistent bronchospasm, we should give due importance, prostration or altered sensorium is very ominous, hypoxia after saturation of less than 95 in pregnancy should be taken with some degree of caution, and CO2 retention is very ominous because usually pregnancy you get a respiratory alkalosis. Risk factors for exacerbations, if the baseline asthma is severe, then that is a risk factor for exacerbation. Obesity, maternal smoking, hospitalization for or ER visit in the last 1 year prior to pregnancy, anxiety, depression, as well as not using inhaled corticosteroids for persistent asthma. These are risk factors for exacerbations. In general, exacerbations are managed in the same way that we manage during a non-pregnant stage. If we need ER care or IP care, fetal monitoring and early consultation with the obstetric team is of paramount importance. We need to monitor the vitals, saturations, blood gases, expiratory flow rates, etc. Maternal positioning, hydration, nutrition, etc. is very important, and supplemental oxygen to keep the target at around 95%. Again, we give aerosolized short-acting bronchodilators. Systemic steroids, I will come to that. Magnesium sulfate may be aminophylline in a cautious way in very, very severe exacerbations, and antimicrobials in infections. So, the relationship of asthma outcomes, there is a significant risk of preterm birth or low birth weight if oral steroids are used for long periods. But for short use during exacerbations, probably I will say that the benefits of these oral steroids in preventing or progressing to life-threatening exacerbations outweigh any risk of steroids if it is used for say 3 to 5 days or something like that, and the doses are similar to that of a non-pregnant lady. I will just have a few slides on respiratory infections very superficially. So it can be a viral or a bacterial infection, is pretty common. Less commonly, we can get a fungal or a parasitic infection. It can be an upper respiratory tract or lower respiratory tract infection, and we have similar diagnostic and management considerations. Again, red flag symptoms, if there is a persistent fever for more than 3 days, pleuritic chest pain, purulent exacerbations, persistent cough, new onset shortness of breath, prostration collapse, lack of improvement over 3 to 5 days, these are red flag symptoms where probably we should refer to a physician or a pulmonologist. And if there are no red flag signs, just go ahead with supportive therapy, there is hydration, nutrition, antipyresis, all those things. If there are purulent expectoration, go ahead with antimicrobials. Diagnostic test for influenza in those settings where it is pretty endemic or epidemic, and empirical oseltamivir is a very good choice in such patients. If bacterial disease, do a CBC CRP, chest X-ray if there is a purulent sputum, pleuritic pain, hypoxia, shortness of breath, etc. Antibiotics, tetracycline, tigecycline, fluoroquinolones, and aminoglycosides are by and large, as a general rule, to be avoided in pregnancy unless the benefits are so huge. Clarithromycin is 50-50 because there are no human studies that show adverse events, but animal studies do. So for that reason, it's a sort of 50-50 drug. Erythromycin, the esterolate salt is better avoided. Other salts are okay with pregnancy. So if I can summarize what I told up to now, asthma is a very common disease in pregnant, common medical problem in pregnant ladies. Some of the available data says that 1/3 worsen, 1/3 remain stable, and 1/3 actually paradoxically improve during pregnancy. Exacerbations are common in the second trimester. The diagnostic and therapeutic approaches are by and large similar. A radiological evaluation, if required, is pretty safe. Don't hesitate on that. Inhaled corticosteroids, that is budesonide, fluticasone is safe. Inhaled long-acting beta-2 agonists, that is salmeterol and fluticasone, are relatively safe based on controlled human data, not RCTs. But the most important message that I want to say here is that the risk associated with uncontrolled asthma is much higher than the risk of drugs or tests. Thank you.
Thank you very much, sir, for the excellent talk. I have got only one doubt. This among these oral steroids, the Flasacort, Dexona, then prednisolone, which drug is more safe?
I don't think we have a huge enough data of one over the other, but by and large, if we require, I think prednisolone would be the time-tested drug.
Thank you, sir.
Congratulations, sir, on the lucid talk. I have two questions. One, asthma in pregnancy is quite common. Up to 8% of patients we do see. And when these patients are referred to you for, stabilizing their pre-conception period and also maintaining good stability in their pregnancy, what would be the important points in your advice?
If we get them pre-conception, what I try to do would be get a basic investigations, the CBC, SR, chest X-ray, spirometry, such stuff. If no much asthma symptoms, all the other blood and X-ray parameters are normal, and spirometry is also normal, with no symptoms at all, I may continue with the SOS beta-2 agonist. But otherwise, anyone having persistent symptoms or abnormality in the lung function test, I am always comfortable going ahead with the combination of inhaled steroid with the inhaled long-acting beta-2 agonist, that combination. We have combination inhalers now available. With that, I feel if we stabilize them prior to pregnancy, the risk of exacerbations or worse outcomes are pretty much low. I prefer a leukotriene receptor antagonist also in a non-pregnant lady. But if in pregnancy, if the patient is comfortable with the ICS LAMA, that is inhaled steroid with the long-acting beta-2 agonist, I will leave it there. If not, maybe add a maintenance leukotriene receptor antagonist also, montelukast.
So you would put them on inhalational bronchodilators?
Yes, inhalational beta-2 agonist, bronchodilators plus inhalational steroid. We have combinations available as a single inhaler.
In a case of acute exacerbation of bronchial asthma in pregnancy, suppose you have admitted a patient and managed with parenteral and inhalational agent, is there any role at all for oral bronchodilators like the theophylline earlier, the acibrophylline?
In pregnancy, I don't think so. Even in a non-pregnant lady during an exacerbation, I don't think those maintenance drugs like the esopropyline or montelukast, they are not acute acting drugs. So probably during an acute exacerbation, I will take them away.
At the time of discharge, will you put them on any drugs oral?
Again, reasonably stable enough to be discharged, again the same stuff. ICS with the long-acting beta-2 agonist. And if the patient has come out after an exacerbation, probably I will err on the safer side and add a leukotriene receptor antagonist also. But probably not theophylline in a pregnant lady. In a non-pregnant lady, or gentleman, I probably will go ahead with the theophylline also.
Thank you, sir.
Very lucid talk, congratulations. Just 2 points. One, about vaccination. In known case of bronchial asthma, thinking of pregnancy, will you advise them to get vaccinated against viral flu or anything? Or
Influenza is pretty safe in influenza vaccine is pretty safe in pregnancy, ma'am. So, but if, as madam said, if we get the patient prior to conception, definitely we will advise. The other second respiratory vaccine that we give is the pneumococcal. Pneumococcal is category C in pregnancy, so once the patient is conceived, I will avoid that. But
Okay.
again, pneumococcal influenza, the indications are pretty broad. Pneumococcal, the indications itself is slightly narrow. We have very well-defined indications based on age and medical comorbidities. So just pregnancy alone is not an indication for pneumococcal vaccine.
what about labor? During labor, what precautions will you take in a bronchial asthma patient?
I had a couple of slides on that, but time permits, I can just go into that. I had 2 slides on that. Okay, if it can be projected.
So, would you advise a loading dose of hydrocortisone in these asthmatic patients when before induction?
If patient is not in an exacerbation, ma'am, no. Whereas if the patient is in an exacerbation, yes. I won't really call that a loading dose. Maybe a 100 milligram, 100 to 200 milligram dose should be more than adequate. I mean, just to dwell, I don't know whether I am late. The peripartum management. So this is what I got. I have no experience on peripartum management, but oxytocin is the drug of choice for induction of labor and control of postpartum hemorrhage. That's what literature says, which I read. Prostaglandin F2 alpha analogs are better avoided. Prostaglandin E2 are considered safer analogs. If high doses of short-acting beta-2 agonists like salbutamol and all such stuff have been given during labor and delivery, blood glucose levels of the baby should be monitored because hypoglycemia can occur. Pain control, morphine and meperidine may be avoided if possible because they can cause histamine release and such problems. Epidural anesthesia is preferred for pain control. If general anesthesia is required, ketamine and halogenated anesthetics have bronchodilatory effects, so if possible, they may be preferred. And bronchoconstriction following use of ergot derivatives have been reported, but may be an idiosyncratic reaction. This is what peripartum management says.
Doctor, regarding chest X-ray, when do you absolutely, like after first trimester, is there any contraindication, like do you have to take with a shield?
Ma'am, as Neeraj was telling in the previous talk, for social comfort sake, you can take with the shield, no issue, because it further decreases the exposure to the fetus and uterus and all those things. But the doses of radiation involved are much small than a teratogenic dose. So hardly, I don't think it causes any major concerns there. Only thing is maybe use your clinical acumen as to whether you need a X-ray in that particular clinical scenario. If yes, just go ahead and do. Maybe for comfort reasons, you can use a shield.
Do we have to tell the patient before taking?
I always say, ma'am, because this is something that at least in our part of the world, the patients always come back and say that no X-ray, no, I am pregnant. So what usually I say is in that childbearing age lady, by default, most of those ladies before ordering an X-ray or even before prescribing a drug, I usually ask a chance of pregnancy. If they say yes, they are pregnant or there is a chance of pregnancy, I say that this doesn't pose additional risk. So the benefits that probably you derive from this X-ray are much more than the adverse events that you think of. So go ahead and do. But the radiology department also takes a second concern on that in most of those hospitals.
Thank you, Dr. Rajesh. I think the messages are clear. Teamwork, treating asthma, identifying the red flag symptoms and signs, inhale steroids, and moreover, addressing the concerns about the drug used in asthma because of its territory. The patients are really concerned. I think that is the most important clinical scenario we come across. Thank you, Dr. Rajesh.